Hi, we are in a new episode of Healthy Life in a different day. We're talking to you from Ankara, Turkey. I have a very valuable guest here, a professor of general surgery. He has joined one of our programs before, and we have talked about gallbladder stones.
Yes.
And today we'll again talk about a specific condition.
Yes, gastric
cancer.
Or stomach cancer.
How are you doing, Hatim?
I'm doing very well, Mr. Serdar. So it is a very wonderful to be with you here and to see
Pleasure's
my
ours.
very sincere and old friend. Thank you very much.
Thank you very much. Thank you very much.
Yeah.
It's our pleasure to see you here.
Thank you very much.
Now, in the days of COVID pandemics, we couldn't pass the other diseases too.
Yes.
And maybe this might have been a disadvantage of many health systems in all over the world.
Right.
Everyone was afraid of COVID infection and could not point out to their indeed more severe problems, such as cancers, such as myocardial infarctions.
Yes.
And I think many patients have been disabled or may have even died because of this problem.
Yes.
One of my oncologist friends said that we are now seeing patients in later stages because of this problem.
Yes.
Thus, I think we have to be careful about social distances and hygiene and look after our main problems in a better way.
Yes.
We must not avoid visiting hospitals and see doctors because of our problems too. And some of this may be very serious, such as gastric cancer.
Yes, indeed.
I'm not an oncologist or general surgeon, so you have to speak about this.
Okay,
what is gastric cancer?
Thank you very much. Thank you very much, Professor Serdar. Gastric cancer, it is a cancer of the stomach. That can be at any part of the stomach. And it is one of the deathful diseases or cancers because the prognosis of it is very poor when we catch the patient or when the patient is diagnosed. You mentioned a very important issue or point that people should not come late, or like your oncologist friend, as he said, the patients come to them in a very advanced or very advanced cases. That is why we should take care about ourselves. And one of the cancers that we diagnose so late is gastric cancer. Unless it is positioned or located in certain locations. That time they give symptoms very earlier, like at the beginning or at the outlet of the esophagus and the outlet of the stomach to the duodenum. That time these two special locations they give us very early symptoms.
Because of obstruction?
Because of obstruction or because of the related narrowing of the lumen of the esophagus or narrowing of the pathway to the duodenum. That is why we see some symptoms earlier. Otherwise, because the stomach is a very large organ, when the tumor is located in somewhere at the body or the antrum of the stomach, might not give any symptoms until it is so late. Yes.
Oh, I see.
Yes.
Then let's talk about the symptoms of gastric cancer.
Yes.
Do they really not give any symptoms, or they are vague symptoms that we can ignore easily?
Yes. As I said, because the organ is a hollow and big organ, most of the patients, they are not aware of their symptoms. Because, as you said, they are very weak and wild, and nobody thinks that this could be a cancer. That is why. When we talk about the symptoms, and particularly the early symptoms of cancer, is one of them is anorexia. Another one is losing weight. Another one is feeling very exhausted and very tired compared to the previous history or compared to the past. These are the generally seen. When it is a little bit advanced, or when it is located at the junction between the stomach and the esophagus, or at the border between the stomach and the duodenum, that time at very early stages they might give some kind of symptoms like very hard swallowing or disability to swallow when it is located at the end of the esophagus. And the patient may feel full very early, eating small amount of food. After that, he feels full. No any desire to eat more. And apart from that, you can see vomiting when the stomach is obstructed or when the esophagus is obstructed. Apart from that, you can see some bloody stool. Most of the time it is microscopic, but sometimes it might be a little bit more, and it can be seen macroscopically. Apart from that, when some patients come with a very advanced disease with metastasis to the liver, they can come with obstructive jaundice. When the lymph node near the gallbladder or near the coloduct, when they are enlarged, so they can also obstruct the coloduct, yes, the patch of the bile, and that time the patient may come with jaundice.
Jaundice, yeah. So these are the symptoms of gastric cancer. As an internist, we generally notice that by anemia in a male patient, or in a female patient who's in menopausal period. In a menopausal period, most of the women do not have anemia. Thus, having an anemia may signify the serious disease in
definitely. This is a very good point too. Some of the people, they appear for the first time with anemia, and particularly the incidence of gastric cancer, it is 2 times in males than in female. Yes, 2 times the rate. And the first symptoms may be related to anemia. Because of what? Because of
you said tiredness.
Yes, losing blood and being unable to eat much and being unable to digest food. So that is why people with anemia, we don't let them go anyhow until we know the reason for anemia.
Do these people develop a different eating habit, like drinking high-calorie drinks instead of eating harder or need to swallow meals?
Yes. When the tumor located in the passage of the esophagus, that time, because it is very hard for them to swallow, so that time they need to have liquids, food.
That's otherwise sometimes they may compensate this. So they have to be careful about changing in dietary habits too.
Yes. And also we as doctors, we have to be aware of the patients history.
Yeah.
As we talked before, having a good history is almost half of the diagnosis.
Yeah.
Yes, yes.
This is very important.
Yes.
So, what causes gastric cancer?
Yeah, as you said, one of the main thing you said, being a female, being a male,
Male.
part. Yes, male sex is one of the factors that play a role in causing gastric cancer. Smoking cigarettes, having drinking a lot of alcohol.
Alcohol.
Yes. Having or eating smoked food.
Smoked fruits.
Yes.
Yeah.
Salty food.
Salty.
Yes.
Really?
Really salty food. And again, as you said, changing habit, eating a very high calorie diet, having a sedentarian lifestyle. You see, all of these can, and some of the formal surgeries, like having a surgery for complicated gastric ulcer. Yes, or some polyps in the stomach, having them removed before. Apart from that, and also having gastroenterostomy, that for any reason to have the stomach being bypassed, all of this, they play a role in developing gastric cancer.
Do bariatric surgeries are encountered within these two? For example,
it is a little bit.
Mini gastric bypass.
Yes, it is a little bit changeable, and it is a little bit challenging. One of the most important things that plays a role in gastric cancer, infectious, particularly Helicobacter. Yes,
really?
Yes, it is one of the very, very important things. And again, reflux. Reflux from the stomach to the esophagus, or from the duodenum to the stomach.
And treatment of the last one is more difficult, huh?
Yes.
The reflux from duodenum to
the stomach. Yes, yes. That one needs some kind of a little bit complicated operation.
In that case, the acidity becomes more alkaline.
Yes.
And this may hurt the stomach.
Of course, this is the main
This is very interesting.
It is.
In fact, acid destroys everything, but here the alkali.
Alkali. Yes, that is it. God. Because of the what they call the physiology of the body.
Everything needs to be in place.
Yes.
No one must enter the other zone.
Yes, no more, no less.
Okay. These are the symptoms and causes of gastric cancer. Once again, some people want very hot food. Some want cold foods.
Yes.
For example, I have been away from home for lots of years, as you.
Yes.
You have been very far.
Yes.
I have been somewhat less far. But we are far from home, and we could eat whatever we have found.
Yes.
Indeed.
Yes.
Does this also affect? Because in our homes, generally in Turkey, people cook hot food.
Yes.
I generally don't like, because I am not accustomed to eat more warmer ones. Yes. Does it also affect?
This one, it affects a little bit not in the gastric cancer, but in the esophagus cancer.
Esophagus?
Yes, because it really hits the esophagus and causes thermal injuries when the food is very hot and when it is repetitive. See? Yes, once or two times by chance. You may eat, no problem. But if it is a usual, or it is become periodically or always you do that, so the risk of gastric cancer increases.
Is this due to hot food or cold food?
Hot food.
Cold does not harm.
Cold, because no problem, because we don't bear so cold food or so cold We don't eat so cold food.
That's
why
I
yes,
like cold.
Yes, yes. Good, good. That is a good things.
Very good. Okay. Then these are the symptoms
Yes.
and causes of gastric cancer.
Yes.
But how do you diagnose it? How
Yes.
does someone diagnose
Yes.
or
Yes.
suspicion of
Yes.
a
Yes.
gastric cancer?
Yes. Yes. These patients, to diagnose, as I said first, you have a good history. And when you have a good history, then you have suspension or suspect of what? Of gastric cancer. Or you need to verify or to make a differential diagnosis of other diseases which are not cancer, benign diseases, like ulcer, like normal reflux, like gastritis without Helicobacter pylori. And then the very golden method to diagnose is endoscopy. And diagnosis is very important for us to be very early. That time, the patient could be cured totally from the gastric cancer, as if he didn't have a cancer.
It can be cured in the early stages. This
Yes.
is very, very important because it's highly lethal in advanced stages.
Yes. Yes. So with endoscopy, we can see the location of the tumor, and then biopsy are taken to
tissue biopsy are
tissue,
taken.
yes, to
pathologist examines
yes,
them.
the pathology will show yes, this is a cancer. Then after that, some evaluation of the patient to which type of treatment. Having CT scans, having PET-CTs, having ultrasonographies particularly to the liver, or sometimes MRI, to evaluate the patient, whether this patient's treatment should be at first surgically or should be chemotherapy and then after that surgery, or to be surgery plus very different kind of chemotherapy that used by us.
We'll come to that, but I wonder, you said diagnosis is important, but you have to make a differential diagnosis from benign conditions to This is very, very important. Can benign conditions also mimic gastric cancer?
Yes, sometimes.
Sometimes.
I
think this is why you take biopsies in several regions when you see even a benign lesion over there. Even as I know, response of a gastric ulcer to treatment, mostly done by proton pump inhibitors, the drugs ending with prazole, omeprazole, lansoprazole, pantoprazole, lots of prazoles. And they're indeed very effective. And indeed, they have prevented lots of surgeries, which was done 40 years ago. Now, almost no one does surgery for ulcers. This is a very important treatment, but healing of an ulcer with these medicines does not rule out cancer.
Definitely. What I will want from my patient, what the advice that I should say is that not to use drugs without their doctor's consultation or decision. Because sometimes when you have ulcer, you may have bloating, you may have again heartburn, burns. That time when you consume these drugs, the symptoms will subside and then the patient will come at a late stage. So an ulcer should be first diagnosed through endoscopic examination, not with only history, and because there isn't another way to put the diagnosis of gastric ulcer.
Yeah.
So,
Then, when the patient is diagnosed to have gastric ulcer,
yes,
you may take biopsies over there.
Yes.
This biopsy may be even come benign.
Yes.
Then you give the treatment.
Yes.
But you have to check again
Yes.
with endoscopy
Yes.
whether it has healed.
Yes.
And maybe take another sample, tissue sample from there to rule out the existence of a malignancy
Yes.
over there.
Yes.
Especially 3-4 gastric cancers.
Yes. In fact, we have what we call malignant ulcers. These, they are, when we talk about ulcers, we have ulcers commonly at the duodenum and stomach. The one that at the stomach, they have the tendency to be malignant, you see, and particularly those ones, those large ones, more than 2 centimeters in diameters. This one, most of the time, biopsy should be taken from there, because might be a malignant, yes, ulcer.
That's very good. You said male patients.
Yes.
Especially if he had a surgery previously.
Yes.
And if he has anemia. This is very important.
Anemia. And again, I forgot one important age. That is age above 50 and above.
50 and above.
Yes. And having a family history of gastric cancer plays a little bit in increasing risk of gastric cancer.
I see.
Yes.
Thus, these people must have an endoscopic examination.
Yes. When they have
symptoms. It's very easy.
Huh? It is. In fact, it is not like formally. Now the people they have, they give them general anesthesia. They don't feel anything. And then when they get up, even they ask whether the procedure is done or not, because they don't feel anything. Not
That's
like before doing it with local anesthesia.
Local anesthesia.
Yes.
And general, sometimes in between, local and general.
Yes. Both.
He can awake easily.
Yes. No
and
problem.
do his job afternoon.
Yes.
Go to anything he wants.
Yes.
That's very easy and important. And even a cheap procedure,
It is.
It was very expensive before.
Yes.
But it's now very easy and very cheap.
Because now the doctors that are performing endoscopies, their number increased. And
I think also device has been, the price of device has been.
Yes, the device became a little bit more sophisticated. And as you said, we have more devices.
That's very good. Hatim, I think we should take a break now.
Okay.
Commercial break.
Yes.
Then let's talk about the treatment options of this cancer.
Okay. Right.
That's okay.
Okay.
Thank you.
Yeah.
Hi, here we are again with Professor Dr. Hatim Yahya Mahmud, talking about gastric cancers. We have talked about the properties of gastric cancer, the causes of gastric cancers, and the symptoms of gastric cancers, and also the diagnosis of gastric cancer. Indeed, it's not so hard to have a diagnosis, and it's not expensive either. Yes. But it's life-saving to be diagnosed at the very early stages.
Yes.
I think afterwards we'll talk about the prognosis of that too.
Yes.
And I think as in every disease, the advanced stages result in poorer prognosis of them.
Yes.
So before that, let's talk about the treatment options of gastric cancer. You have mentioned something that we do then some more tests to evaluate the patient and decide according to those results about what to do first.
Yes.
Surgery or some other therapies, and then after surgery. Are there options other than surgery for this? Are there any patients you do not perform any surgery?
Okay. Yes. 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 Yes That is
I
not.
think surgery is a gold standard here.
Yes, it is. It is. And when the cancer is diagnosed as very early stage, only being contended in the first layer of mucosa, at that time, even endoscopic resection without leaving any cancer could be enough. But it is very difficult to catch a patient at that stage. Yes. We always look forward to find a patient or to diagnose a patient at what we call operable or operative stage, because the cancer, when you catch it at the early stage without making metastasis to the nearby organs like the liver or the transverse colon, that time you can cure the patient totally. Yes.
That's
some patients, when they are caught at early stage, they even don't need systemic chemotherapy.
That's very good.
Yes.
That's very good.
Yes. All our aim is to do a radical surgery. What I mean by radical, that to have a patient being terrible, being well fed and fit for this kind of operation. What I mean by that, that to remove the whole tumor with what? With the surrounding lymph nodes, because the very early metastasis is to the regional lymph node, that the lymph node around the stomach, as it is shown on this slide. So there you can see the stomach, you can see the lymph node around. So this is a radical surgery for this patient. Is the sometimes when, according to the location, when it is located at the upper part of the stomach, then the patient needs to have the whole stomach removed out. When it is located distally, the patient might have only the distal part, what we call subtotal gastrectomy. Yes.
That's good.
So this is the first aim. Before, when the patient, they have some kind of metastasis, or when they are caught at a little bit advanced stage, most of the patients are announced as non-surgical patients, and that time the role of chemotherapy and immunotherapy plus radiotherapy can play a role, but none of them is so effective.
So effective.
It is not. They are not effective. Sometimes all these people or these patients with advanced tumors, they need again surgery, what we call palliative surgery, not radical. What I mean by that, that to have a surgery to make the symptoms to get a little bit lower, and to make the patient relaxes and have a well quality life compared to the previous time. Like what? Advanced tumor which blocked the esophagus. So this patient cannot have anything orally.
Yes.
Yes. Second, advanced tumor with obstruction of the way to the duodenum. That time the patient cannot pass digested food to the intestine. So that what we do, we make a bypass to work to do what? To bypass the
blockage.
The blockage.
Yeah.
Yes. The
Thus
block
the food
area.
can
Can go without going to the duodenum. They just go to the jejunum or the other part of the small intestine.
So a patient can indeed,
in fact, yes,
eat something.
Yes, can eat something and
not lose weight.
Yes.
That's good. So we have radical surgeries and palliative surgeries. You said that sometimes we can even protect some part of the stomach too.
Yes.
In those patients, you have made radical total gastrectomy patients.
Yes.
We have removed all of the stomach.
Yes.
Do they have any problem? How do they eat after that? We always say that every organ is important. Stomach
Yes.
is also important.
Yes.
So you are removing stomach.
Yes.
How do these patients eat?
Yes. Şimdi
I have lots of patients.
Yes.
They are very good.
Yes. In fact, every organ is important when it is not diseased.
Diseased.
When it is diseased, it is not important. At that time, it is a problem. When you take all of the stomach out, then we join the esophagus with the small intestine, and then part of the small intestine to other small intestine. Why we do that? Because food will come from the esophagus to the small intestine, and because you took the whole stomach out, then pancreatic secretions and bile should come from other way.
Yeah.
So that time we do like this. This patient at the beginning, it depends on the technique and how the surgeon is experienced in this type of operations. At the beginning, of course, these patients, they have some problems with particularly when the stomach is took out, they don't feel hungry. So that time, we as doctors, we really teach the patient to eat 6 to 8 times a day. Again, the functions of the stomach is one of them is to be as a storage organ.
Yeah.
When you eat, the meal stays, or for the whole meal to pass through to the small intestine, it needs about 6 to 8 hours. So now we don't have a stomach.
Yeah.
So because of that, you eat very little.
Yes.
So that time, at the beginning, the patient, they cannot eat properly and they don't feel hungry. That is why they don't eat well. And because of that, they lose weight, and they have some deficiencies in some vitamins, and in also they may have anemias. So that is why, according to that, their diet should be regulated, or should be yes. Yeah.
When can they eat regularly? I think at the beginning they only can swallow fluid, like some soups, without anything in them.
Yes. In fact, if no problems happens, what I mean by that, no complication take place, then the patient after the 5th to the 6th day can eat solid food.
6 days later?
6 days.
Really?
Really, 6 days. After 6 days.
Yes. It's quite early. Huh?
Yes.
Very good.
Yes. Now, of course, we have changed the style of now feeding, and particularly oral feeding, is very important for the patient's health. As earlier you start eating, is better the patient will be.
Sure.
Yes.
Sure.
That is why we start immediately. Sometimes we use a different kind of feeding, that we put a tube below the anastomosis, where the small intestine come with the smallest intestines, distal to that, and after 24 hours we start feeding the patient.
Oh,
yes.
Very good.
This will be good for the patient health, and will be good for the preparing the patient for systemic chemotherapy if he needs.
If he needs, yeah.
Yes.
As in most stressful situations, going back to routine is very important in everything. It also helps to helps the intestines also to have its regular motion too.
Yes.
That's very good.
Yes. Otherwise, we have some, as you know, this what we call bacterial translocations, because the patient is not the good bacteria that we have. It also needs what? Needs food.
That's very good. After that, If the patient needs, he may have chemotherapy,
Chemotherapy,
or
radiotherapy.
radiotherapies.
In fact, the gastric cancer treatment is multidisciplinary. The patient needs a surgeon, medical oncology, and medical oncologist, yes, oncologist, and radiologist, and also radiotherapy specialist.
At the beginning, a very good pathologist.
Yes, yes, of course. This is the main point.
Yeah.
This is the point where we start.
Yes. So these are treatment options.
Yes.
Or because they can be made
Surgical treatment options. Yes.
Yeah. What's the prognosis of this disease?
It depends on the stage that you catch the patient. If you catch him in stage 1, that
Cure.
Cure.
Yeah, very good.
Yes. If you catch him in stage 2, again with good radical surgery, that will be very
Optimistic.
good. Yes.
Very good.
Yeah, that is why. But after stage 3, things get mixed.
Things get mixed.
Yeah, that time the patient will be taken into the consultation and to evaluate the patient. What will gain and what will he be losing?
Yeah.
Because sometimes the tumor be located in somewhere where the patient cannot eat anything. That time, although the surgery is not radical, it will be palliative, but the lifestyle of the patient or the what the quality of the patient will be better.
Sure.
Yes.
A patient who cannot eat will be start to eat.
Yes,
This is
yes.
also very important.
And this also preparation for what? For chemotherapy or radiotherapy, because you need energy and you need good immune system.
Yes, yes, of course.
Yes.
And this is the prognosis. There's a strange option.
Yes.
There's a chemotherapy option, but not performed by oncologists.
Yes. This kind of treatment developed in the last 10 to 15 years. Now it is not accepted by some doctors. It is a kind of what we call local chemotherapy.
Local chemotherapy.
Formally, those patients who have advanced gastric cancer, like metastasis to peritoneum, or metastasis to the ovaries in the male patients, or with direct invasion to the liver, or with direct invasion to the transverse colon. These patients are considered as peritonitis carcinomatosa at very advanced stage, and if the tumor location does not block the patient's digestion system, so no need for any kind of surgery. They consider that, and they only give chemotherapy, which is not by itself enough treatment or good treatment. So with time, the authors developed a kind of chemotherapy that we should not mix this kind of chemotherapy and the systemic chemotherapy which is performed by oncologists, because having this kind of chemotherapy does not prevent having the other one. The systemic chemotherapy.
The systemic chemotherapy must be continued.
Yes.
Besides that, you will perform this HIPEC.
In fact, this HIPEC or hyperthermic chemotherapy is performed immediately after the operation. Or sometimes we prepare the patient and we perform it 24 hours later if the condition of the patient is not so well during the anesthesia, because these patients with very advanced gastric cancer, they need a very radical surgery. That what we mean by radical surgery, to remove all the tumor that you see by eye. What we call gross tumor will not be there.
Yeah.
Only tumor at the level of what? Of cells, which we cannot see, will be there. What we do, we put 4 pipes in the stomach, and then after removing all the tumors and everything, and after making the hemostasis and no bleeding, no any something else, then we close the abdomen with these 4 tubes, and we have a system. It looks like as a system of what? Of this dialysis or system that is used to open heart surgery. We have a machine. This machine have an ability to round or to give and take fluid into the stomach and from the stomach.
Yeah.
You see, using different passageway. What I mean by that, giving fluid with chemotherapy from the below 2 pipes or tubes, and taking it out from the upper ones. Later, after 15 to 10 minutes, give it from the upper and take it from down. Give him from the left, from the right, and take him from the left. Give him from the left and take him from the right. With this, the hot chemotherapy will be, or the whole abdomen will be exposed to this kind of chemotherapy. Why hyperthermic chemotherapy? Because the tumor cells, they are very sensitive to heat, considered with normal cells.
Normal cells.
Yes. We heat this. We have a thermometer that, and the device, it will heat this chemotherapy up to 40 or 42 degrees. This 40 to 42 degrees do not harm the normal blood cells. It only harm what? Harm the tumor cells. So with this kind of technique or with this kind of treatment, we really, I cannot say all of the patients will get benefits from this, but most of the patients will get benefit from this kind of treatment when the patient is able to stand this procedure, because it is a long procedure and it needs the patient to be in a good health. That means we feed the patient before performing this kind of operation, and also we give very full information to the patients and to the patient's family about the procedures and about the if we talk about complication, no more complication, or like this, the systemic chemotherapy, we don't see complications, because this kind of treatments, the period is about 1 hour. Then after that, the patient will be
resting.
Yes, resting, and most time we take the patient, if it needs, to the intensive care unit or to the wards.
I see. How long does this last? The one session is 1 hour.
1 hour.
How
yes.
many times will you perform?
Only once.
Just once?
Yes, only once.
You said a long time, just 1 hour?
Yes, just 1 hour.
Oh, that's
then,
easy. Then.
Again, there is another thing, is that if the patient is doing fine and everything is all right, 2 years later, he might need another HIPEC, and he might not. It depends on the follow-up that is done by the oncologist.
That's right.
Yes, yes.
I think you are experienced with HIPEC.
Yes, I have.
You have lots of patients
yes.
doing this. How are they now?
Some of them, I lost about 2 patients, because these 2 patients, after the diagnosis and after my decision to have what we call hysterectomy surgery is the removal of the whole tumor in the stomach, in the abdomen, and giving HIPEC. They didn't come. They came 6 months later after this. So that means it is a very late stage. But they insisted on to give a chance to their mother.
Okay.
So that patient I lost. I have one patient when we came to me, he has a very advanced tumor in the peritoneum, omentum, ovary, rectum, and
everywhere.
Yes, everywhere, and even the gallbladder, the bladder. Yes, I make a resection to the stomach, to the rectum, and make anastomosis, and I did surgery, or I removed the peritoneum where the tumor is spread. And then after that we performed. And now I have 2 patients who are doing so well, and it is more than a year past. Yes, after the treatment. Now they are doing fine.
Then there may almost be some hope.
Yes.
And we have to try to find the right treatment and
decision.
Right place to make this one.
Yes. Yes.
Dr. Hatip, thank you very much. This has been a very delightful speech with you about a not delightful subject, but indeed sometimes curable subject.
Yes.
Thus, as in everything, we have to be careful and try to be diagnosed as early as possible to have the best treatment option.
Yes, that is it. That is it. And my last advice is this: we can't avoid gastric cancer, but we can minimize the risk factors of that. So thank you very much. It is a pleasure to me to be with you.
What is your last advice about minimizing risk factors? What do I have to? I have to lose weight. Okay. What else? I cannot be a female after now.
Of course, of course, of course. Those with diabetes, they have to control their sugar level.
Stop smoking.
Yes, stopping smoking is very, very good, or decreasing smoking. Those who have alcohol abuse, they should be treated from alcohol abuse. Those who are eating smoked food, they should decrease the amount of food that they are eating. Those who are eating salty food, they should avoid this kind. And I forgot something, that gastric cancer is very common in Asia, and particularly in Japan and in Korea. Yes, because of these eating habits. So an exercise, if can be done, will be very good for reducing the risk of getting gastric cancer.
This has been a very good wrap up. And please, you have 30 more seconds to say something to your family and to everyone in Africa.
Of course, since I am of Sudanese origin, firstly, I want to greet my family, my mother, my sisters, and my cousins, and I would like a good time for both Sudans and for the whole of Africa. I say hello, take care of yourself, and when we are needed, we are always there. Thank you very much.
Thank you very much, Dr.
Thank you, thank you.
And we always want you here.
Yes, that I'm all the time I will be ready for that.
Have a good time, Africa.